Hi, my name is Jennifer Maranke, and I'm the Director of Endoscopy at Penn State Hershey Medical Center. I'm pleased to be here with Dr. Chen from McGill University in Montreal, Canada, who's here to talk about his study, the cost-effectiveness analysis comparing lumen-apposing metal stents with plastic stents in the management of pancreatic walled-off necrosis. Thanks so much for being here today.
It's my pleasure to be here. Thank you for inviting me.
So where did you get the idea for the study?
So as you know, endoscopic drainage of wall-off necrosis has been really popularized with the advent of the lumen-apposing metal stent, the ease of use, the larger diameter. But obviously one of the challenges is it's a very expensive technology. So we thought this study was timely with the fact that many centers are thinking about adopting this technology worldwide, not just in North America. And we thought that a cost-effective analysis would be very helpful in trying to delineate indications and whether it's even cost-effective to use this tool in this indication.
One of the concerns with lumen-apposing metal stents is the risk of bleeding. How did you calculate for this in your study?
So the risk of bleeding really came about in the preliminary results of Dr. Varadaraju's study showing an increased risk of bleeding. Interestingly, that hasn't been demonstrated in other papers. This was really the first paper that really demonstrated this adverse event. But we did include any adverse event associated with the lumen-apposing stent insertion needing a re-intervention, either surgical or interventional radiology or endoscopic. So we do account for any kind of bleeding risk associated with this into the cost model.
Okay. And how was your study carried out?
So this is a decision tree analysis. So everything was based on a decision tree analysis with the important health state that we thought was the most common and most looked for in endoscopic drainage, including technical clinical success, need of surgery, need for percutaneous drainage, and adverse events needing reintervention. The probabilities were generated from the literature through a systematic review of all studies stemming from 1992 to 2016 involving endoscopic drainage using either the lumen-apposing stent or plastic stent. And we acquired the cost data from Johns Hopkins University at the hospital, and we converted it to charges, from charges to costs using the Medicare and Medicaid costs to charge ratio. So that's pretty much the base, the backbone of the design of the study. And looking at effectiveness, the unit effectiveness, which is successful drainage without need for surgery or percutaneous drainage.
And what were your findings?
So interesting, our findings is that the lumen-apposing stent was shown to be more effective than the plastic stent. This isn't something new. I think many studies have shown that. We also showed that it led to less reinterventions and less need for surgery. So those are the major clinical endpoints. But interestingly enough, we did show that, yes, the lumen-apposing stent is more costly per patient, around $20,000 over a 6-month period, versus around $16,000 for plastic stent. But if you look at a willingness to pay threshold of $50,000, which we adopted a priori to the study, it shows that the cost effectiveness favors lumen-apposing stent. So this means for each successful drainage, you're willing to pay up to $50,000 more. And that threshold is kind of subjective, but is an acceptable threshold that we use in other parts of medicine, such as GI bleeding and even oncology. A $50,000 threshold is really acceptable in terms of cost effectiveness.
So how did lumen-apposing stents become potentially more favorable in this paradigm of with a threshold of $50,000?
It led to more effective treatment. So that's the major issue, less reintervention and less need for surgery. So overall, although overall it costs more, it doesn't cost more than $50,000 to achieve one more successful drainage than plastic stent. So in our mind, that's it's an acceptable cost that at that threshold we deem to be cost effective.
Got it. What do you think are the major strengths of your study?
So I think the major strength of the study is that we conducted a systematic review of the literature. The second thing is that we did extensive sensitivity analysis. So we varied each probability, each cost in the model with 10,000 variations to show the robustness of our results, which did not change our conclusion in terms of the cost effectiveness. So I think those are the major strengths of the study.
What about the weaknesses?
So the major weakness is the fact that there's no randomized controlled trial. We use data from retrospective and also prospective series of patients undergoing lumen-apposing metal stent or plastic stents. It would be nice to have randomized controlled trials. The other weakness is that the cost data comes from one center. at Johns Hopkins University. However, we did, like we said, vary the cost of each part of this model by large amounts to try to account for different cost models and different healthcare models to try to generalize our findings.
All right. So what's the bottom line based on your information?
So we believe that using a lumen-apposing metal stents with a minimal willingness to pay threshold of $50,000 is cost effective in wall-off necrosis. Now, it's very important to preface that this is not for pancreatic pseudocysts. This is pancreatic wall-off necrosis.
Great. Thanks so much for your very interesting study. I look forward to seeing how the field of treatment of pancreatic necrosis progresses with this information.
My pleasure.
Thank you.
Thank you. Thank you.